Hello everyone. So on 24th March every year we have the occasion of the World Tuberculosis Day. So today we discuss about unwanted effects of antitubercular drugs. Now antitubercular drugs, they are effective for treatment of tuberculosis, but they can cause a number of adverse effects. These adverse drug reactions, they are a great challenge to the National Anti-Tuberculosis Program. So, therefore, there is a need for having awareness and continuous monitoring about the adverse effects of the antitubercular drugs, both the older established drugs as well as the newer drugs. And if we do the proper monitoring about these adverse effects of these antitubercular drugs, then we can also benefit in terms of prompt treatment of the tuberculosis. Now, let us understand first what are these adverse drug reactions. As we know, clinicians and patients acknowledge the major role which is played by drugs in the modern healthcare, and understanding how the drugs affect the body homeostasis at the molecular level, it serves foundation for developing new therapeutic agents which forms the basis for the rational pharmacotherapy. Now we know that drugs exert their beneficial effects, but also along with the beneficial effects, drugs can also cause the adverse drug reactions. So this therapeutic dilemma gives credence to the statement that there are no absolutely safe biologically active agent. So therefore we must understand that when drugs produce their beneficial effects, there also has to be some amount of the adverse drug reactions which we should uh, try to detect them as early as possible, and we can monitor them, and as well as we can also treat these adverse drug reactions. So study of the adverse drug reaction comes is under the field of pharmacovigilance, and as we know, pharmacovigilance is in the during the post marketing phase. So we do the during the phase 4 studies, we do the post marketing surveillance, and we study these adverse drug reactions. So WHO has given this definition for the adverse drug reaction, and this is a response to a drug which is noxious and unintended, and that occurs at doses normally used in men for prophylaxis, diagnosis, or therapy of a disease. And response to a drug means there is a causal relationship between the drug and the adverse drug reaction. That is, there is a causal relationship between the therapeutic agent and the adverse drug reaction. So then it is the response to a drug. So, what is this adverse drug effect or adverse drug event? It refers to any injury occurring at a time when the drug is used, whether or not it is identified as the cause of injury. So, here it is not necessary to have a causal relationship with the treatment. So, we can understand that adverse drug reactions, they are a special type of the adverse drug event in which causative relationship is shown, isn't it? So we can understand this by a very simple example, like we use antihistaminics for treatment of the minor allergic reactions. So these antihistaminics, they will cause the adverse drug reaction, that is sedation or drowsiness. So this is the adverse drug reaction. And adverse drug event means this patient on antihistaminics, he drives a vehicle and he meets with an accident. So this is a event, adverse drug event. So in this way, we can treat this adverse effect, adverse drug reaction, that is drowsiness, by giving, say, by giving a drug before the bedtime. So in this way, we can monitor the adverse drug reactions, and also we can treat these adverse drug reactions. So grading of the adverse drug reaction. The adverse drug reaction may develop promptly. So it can be acute, which is occurring less than 60 minutes, that is within an hour. It can occur after some time, so it is subacute, occurring between 1 to 24 hours, or even after stoppage of the drug. So it is a latent adverse drug reaction which may occur after more than 2 days. Severity of adverse drug reaction is graded as mild, moderate, and it can be graded to severe illness leading to the hospitalization, permanent disability, and also it can be lethal, causing the death of the patient. So we must try to understand the adverse drug reaction. So a simple classification will also give us an idea about the mechanisms involved in different adverse drug reactions. The type A adverse drug reactions, type A are the augmented reaction. This is due to the known pharmacological effect of the drug. Type B is the bizarre reaction, which is unrelated to the drug's known pharmacological action. And type C is the continuous or chronic use of the drug, which gives the adverse drug reaction because of continuous or chronic use or for a prolonged period. So the dose and duration of the drug use influences the adverse drug reaction. The best example is ethambutol induced optic neuritis. Then type D is the delayed type of reaction which occurs long after stopping the treatment. And type E type of reaction, the effects occur due to sudden discontinuation of the drug after prolonged use. So for example, there is increase in the frequency of the seizures on sudden withdrawal of the anti-epileptic drugs. Then there is another one, that is type F, or unexpected failure of therapy. This is a type of included in the adverse drug reaction in some of the literature. It is mentioned type F type of reaction, which is the unexpected failure of therapy. And the best example is decrease in effect of antitubercular drugs due to the development of resistance. So in this way, we can see the type A reaction, augmented reaction, further classified into side effects, secondary effects, and toxic effects. We'll come to that. And the type B reactions, they are further classified into the idiosyncratic reaction and allergic reactions. The idiosyncratic reactions are genetically mediated, and the best example could be a drug like sulfonamide, which can induce the hemolysis in the patients with G6PD deficiency. Or allergic reactions, these are immunologically mediated reaction. Now, among these allergic reactions, there are type 1, type 2, type 3, and type 4 reactions. We are concerned with the type 2 and type 3 reaction in relation to the antitubercular drugs. We can see type 1 reaction is the anaphylactic reaction, where there is drug induces the IgE antibodies, and there is antigen antibody complexes are formed, and there is degranulation of the mast cell, release of different mediators, and like the histamine, leukotrienes, platelet activating factor, and it is giving rise to anaphylactic signs and symptoms. There is bronchospasm, there is laryngeal edema, and there is hypotension. So the best example could be drug like penicillin, lignocaine. Now we are concerned with type 2 reaction, that is the cytolytic reaction, in which these antigen antibody complexes, they can now activate the complement system. And the best example is anemia due to rifampicin, thrombocytopenia, and there is hemolysis, anemia due to linezolide. So these drugs, they are used in therapy of tuberculosis, like rifampicin and linezolide. So type 3 reactions are the Arthur's type reaction, in which antigen antibody complexes, they are now initiating an inflammatory response. There is occurrence of the vasculitis, that is, this could lead to serum sickness and rashes, fever, arthralgia, and the severe forms could be the Stevens-Johnson syndrome or the toxic epidermal necrolysis. So when there is mucocutaneous manifestation, and the best example could be drug like sulfonamides. And the type 4 reaction is the delayed hypersensitivity type of reaction. So in type 3 reaction, sulfonamides, we can remember in context to tuberculosis, we have all HIV TB patients who are given the co-trimoxazole. Co-trimoxazole contains sulfamethoxazole, that is a sulfonamide, plus there is trimethoprim. So this co-trimoxazole is used to prevent the pneumocystis jirovecii and other opportunistic infections in the HIV TB patients. So we must remember that all these type of reactions are possible. So this is how we are trying to understand classification of adverse drug reaction and an insight into the mechanism of how these adverse drug reaction take place. So The type A or the augmented reactions, these we know that they are related to the known pharmacological effects of the drug. Now, these adverse drug reactions are predictable adverse drug reaction as well as they are dose related. So, dose can explain these reactions. So, first is the side effects. Side effects is the unwanted effect which takes place with therapeutic dose of the drug. Now, the example here, it is hypoglycemia occurring due to insulin or bleeding taking place with anticoagulants like warfarin. And in context to antitubercular drugs, we can remember side effect of rifampicin, gastrointestinal side effect like nausea and vomiting. So this is unwanted effect in therapeutic dose of the drug. Then secondary effects. Secondary effects, these are the indirect consequence of the primary drug action. Now the best example could be superinfection caused due to broad spectrum antibiotics. So here we can remember that a number of drugs which are used as second line drugs in treating the multi-drug resistant MDR tuberculosis. We are using different antimicrobial drugs in different regimes like the amoxiclavulinic acid combination or the imipenem, cilastatin, and also the linezolide. So these antimicrobial agents are used, and you can see there is occurrence of the superinfection. There is the antibiotic associated pseudomembranous enterocolitis. So this is the best example in context to tuberculosis and treatment of MDR tuberculosis. We are using different antimicrobials. Then in toxic effects are seen with higher dose. So just like morphine in overdoses can cause the respiratory depression. And this could be fatal. So it could be serious. So the best example could be pyrazinamide induced hepatotoxicity. So this hepatotoxicity is seen with higher dose of the pyrazinamide. So we can say that the type A or the augmented reaction, these are the most common adverse drug reactions, and they can occur in anyone. So overdose, toxicity, excessive actions of the drug or drug interactions. So these type of adverse effects, the incidence is very high, and basically they are based on the pharmacological property of the drug, and they are basically a type of normal response or a hyper response, and but the mortality is low with this type A or the augmented reactions. And we must remember that most of these adverse drug reactions are common and they are reversible. So we can treat this adverse drug reaction by causing the dose reduction, or we can stop the drug. So we can remember that the augmented reaction, these are the predictable adverse drug reactions, and they are dose related and they are related to the known pharmacological effects of the drug. We must also be able to distinguish between the type A and type B reactions, so that when we are able to properly distinguish, then we can also treat these reactions. So type A reaction, mostly we can reduce the dose. Now let us see what is this type B or the bizarre reaction. These bizarre reactions, these are abnormal responses and they are unrelated from the drug's known pharmacological actions. So they are unrelated, whereas type A reactions are related to the drug's known pharmacological actions. But type B or the bizarre reactions, they are unrelated from the drug's known pharmacological action. They are based on the peculiarities of the patient, and they are unpredictable adverse drug reactions. They are non-dose related. They are not related to the dose, because even small dose can trigger a severe reaction. There is These reactions are less common, so there is a low incidence of these adverse drug reaction, but they are not tolerated. And because they occur only in the susceptible patients, we saw type A reactions, they are very common and they occur in mostly they occur in majority of the cases. But as compared to that, the bizarre reactions, they occur only in the susceptible patients, and also the mortality is high in cases of the bizarre reaction. So we can treatment of this type of reaction is we can stop the offending drug and the reaction may subside. The most common reactions which belong to this group, these are the allergic reactions, that is the immunologically mediated reaction, which we have already discussed. and the idiosyncratic reaction, which are the genetically mediated reactions, as well as intolerance to the drug. So these are the different type of the bizarre reactions. Now coming to the allergic reactions, as we have seen that these allergic reactions, they occur only in the susceptible patients. And the cardinal manifestation of the allergic reaction is positive D-challenge on withdrawal of the drug, so that the reaction stops on stopping the drug. And there is also positive re-challenge. So there is positive D-challenge as well as there is positive re-challenge even with a small dose. So the reaction appears even with a small dose. And the reaction stops on stopping the drug, as well as soon as you do the positive re-challenge, then the reaction starts even with a small dose. So here in the list of the drugs causing allergic reaction, different drugs are mentioned here, and you can see antitubercular drugs, they frequently cause the hypersensitivity reaction or the cutaneous reactions. The first line drugs like ethambutol, then pyrazinamide, rifampicin, and isoniazid. And among the second line drugs, antitubercular drugs, there are drugs like moxifloxacin, para-aminosalicylic acid, linezolide, and clofazimine, which cause the hypersensitivity reactions. Now, if the reactions are minor, we can treat with the antihistaminic drugs. But if it is severe and there is mucosal involvement, like in case severe allergic reactions like the serum sickness and mucocutaneous manifestations in the Steven Johnson syndrome or toxic epidermal necrolysis. In severe reactions, we may have to withdraw the offending drug and the treatment has to be given accordingly. And also corticosteroids could be used to treat the severe hypersensitivity reactions. Now, so, with this background idea about the adverse drug reactions in general, we have discussed the classification and the mechanisms of adverse drug reactions, and we have seen in context to the antitubercular drugs also. We would now like to have an idea and knowledge about the different unwanted effects of the antitubercular drugs. But first, we should try to understand why we should know about the unwanted effects of antitubercular drugs. The interruption in the treatment of tuberculosis. This is the most common reason, and the unwanted effects, the adverse effects to antitubercular drugs, they are the most common reason for interruption in treatment of the tuberculosis. This interruption in treatment of tuberculosis can lead to treatment failure because there are so many adverse effects taking place with antitubercular drugs. So, because of this, patient does not want to take the drug. There is interruption in the treatment of tuberculosis. This interruption in treatment of tuberculosis will lead to treatment failure. It may then increase the cost of the hospital treatment, increase the burden. It will also increase the morbidity and it will decrease the quality of life and also cause the death of the patient. Therefore, the thorough working knowledge of the adverse effects and how to treat them is very, very essential. So here we can see the first line antitubercular drugs, isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin is an aminoglycoside and it is a first line agent, which is an injectable drug and it is a aminoglycoside. Then in the second line drugs, we are having fluoroquinolones, fluofloxacin, levofloxacin, moxifloxacin, ciprofloxacin. And there are other core drugs orally which are used like ethanoamide, prothionamide, cycloserine, terizidone, para-aminosalicylic acid, rifabutin, and rifampicin. Now, there are other injectable drugs among the aminoglycosides, but these drugs are under the second line drugs. These aminoglycosides, injectable aminoglycosides, are the kanamycin, amikacin, and capreomycin. So these are the second line agents among the aminoglycosides. Whereas streptomycin is a first line agent and it is also aminoglycoside, which is an injectable drug. So we can see here, this is the guidelines as per the RNTCP Guidelines 2016, Revised National Tuberculosis Control Program. And here we can see the duration of the treatment for the drug sensitive tuberculosis, or in the WHO term, it is also known as non drug resistant tuberculosis. So, this is drug sensitive tuberculosis, and we can see here 5 drugs they are used to treat the drug sensitive tuberculosis, that is isoniazid H, rifampicin R, pyrazinamide Z, ethambutol E, and streptomycin is S. Let us see the adverse effects of each of these first line drugs one by one, and also how we can monitor the antitubercular drugs. Now, isoniazid, it causes the side effect peripheral neuritis, as you know very well. Isoniazid, this toxicity is caused due to competitive inhibition of the pyridoxine. And we know pyridoxine is deficiency will lead to the neurological manifestation like paresthesia, peripheral neuritis, and ataxia. So, this peripheral neuritis can be treated, it can be prevented by pyridoxine supplementation. Hepatitis. Isoniazid induced hepatotoxicity causes mild elevation of the liver enzymes and mostly not requiring the cessation of the therapy. But if it is severe, then we have to discontinue the drug or we have to stop the drug. So, monitoring of this hepatitis can be done by estimation of the liver enzymes, SGOT, SGPT. Central nervous system side effects like mental disturbances and also in rare cases the convulsions can take place. Then hypersensitivity reaction like skin rashes and drug interaction with isoniazid. Isoniazid is an enzyme inhibitor drug and it can inhibit the metabolism of the other drugs which are given along with it like carbamazepine, phenytoin, azole antifungals and alcohol. It will inhibit the metabolism of these drugs and by increasing the levels may lead to toxicity. Rifampicin is an enzyme inducer drug, so when it is given along with isoniazid, it counteracts this particular action of isoniazid. Then coming to rifampicin causes the side effects of discoloration of the uh, urine, that is orange urine, tears and saliva. And for this, you can just do the counseling of the patient and you can reassure the patient. For flu-like syndrome, like chills, fever, and headache, you need not discontinue the drug. And as far as hepatitis is concerned, so hepatotoxicity, we occurring with rifampicin, we have to estimate the liver enzymes, SGOT, SGPT, or also the bilirubin. And you can discontinue the drug if there is jaundice or there is increase in the liver enzymes. In cases of thrombocytopenia, hemolysis, and renal failure, we have already discussed the mechanism. We have seen the cytolytic reactions, so immunological reactions because of which this type of adverse drug reaction take place with rifampicin. And for thrombocytopenia, we can do the monitoring of the platelet count. But because of this reaction, we may have to discontinue the rifampicin. Drug interactions with rifampicin. Rifampicin is an enzyme inducer drug and therefore it increases the metabolism of other drugs which are given along with rifampicin and it may decrease the efficacy of these drugs. So number of drug interactions are possible because of this enzyme inducer property of rifampicin. Then coming to pyrazinamide. Pyrazinamide causes hyperuricemia. So we may have to monitor the uric acid levels and this hyperuricemia is very common and also it can cause the arthralgia which is transient and it subsides. So we can treat with the non-steroidal anti-inflammatory drugs. Also hepatotoxicity, we may have to do the estimation of the liver enzymes SGOT, SGPT, and this hepatotoxicity is more common with the high dosage of the pyrazinamide. So we must be careful when increasing the dose of pyrazinamide because this is more common with the high dose of the pyrazinamide. Also, gastrointestinal side effects like abdominal distress can take place, and it is seen that in cases of diabetics, the blood sugar monitoring should be repeated while giving the pyrazinamide. Then ethambutol optic neuritis. This is uh, occurring after more than a month of the therapy, and it is reversible, and we may have to do the monitoring in by the monthly eye examination to assess the visual acuity and the red green color discrimination. This optic neuritis is not seen with the therapeutic dose of ethambutol as we go on increasing the dose, and it is seen after more than a month of the therapy. So dose and duration of the therapy, and this we can get the this optic neuritis occurring with the ethambutol. So monitoring has to be done by the monthly eye examination. Also, we need to be cautious in presence of the renal insufficiency. Then streptomycin, we know it causes the eighth cranial nerve damage, so ototoxicity and nephrotoxicity. So for ototoxicity, we can do the monitoring by audiogram vestibular of the vestibular function, and also it should be used cautiously in the presence of renal insufficiency, because the drug excretion is affected in presence of renal insufficiency, which will lead to more of the ototoxicity. And the vestibular toxicity is manifested as dizziness, giddiness. Besides nephrotoxicity, we need to monitor the creatine levels and the blood urea nitrogen. And neuromuscular junction blockade, this is seen in patients receiving the muscle relaxants. So more occurrence of the neuromuscular junction blockade in patients who are receiving the muscle relaxants. Also the hypersensitivity reactions take place. Let us now see the second line drugs which are used for treating the drug resistant tuberculosis. The second line drugs, we must remember that these are less well tolerated drugs, and these are used in cases where there is resistance to the first line drugs, or when the first line drugs are not tolerated or they are contraindicated. And different drugs are there, as you can see here. In the group 1, we have the first line drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, also streptomycin. These are the drugs which are in the first line drugs, and we are using streptomycin for drug sensitive tuberculosis. Then in second line drugs, we are having the other injectable aminoglycosides like kanamycin, amikacin, capreomycin, which are used for the drug resistant tuberculosis. Then fluoroquinolones like ufloxacin, levofloxacin, moxifloxacin, ciprofloxacin. And there are group 4 or the other core oral drugs, so like ethionamide, prothionamide, cycloserine, terizidone, para-aminosalicylic acid, rifabutin, and rifapentin. And in the group 5 drug, we have certain add-on agents like the clarithromycin, clofazimine, linezolide, amoxicillin, clavulanic acid, and imipenem, cilastatin. So these are the different add-on agents. And then we also have a newer drug like bedaquiline, which is in the WHO list. So when we formulate the different regimens for the multi-drug resistant tuberculosis, we use drugs from these different groups. So these are the second line antitubercular drugs. Now let us see the adverse effects of the group 2, that is the injectable drugs like kanamycin, amikacin, and capreomycin. Now these are aminoglycosides, and we know the common toxicity which is there, like ototoxicity, nephrotoxicity, and effects on the neuromuscular junction. So these are common to all aminoglycosides, and accordingly we can do the monitoring of the audiogram, the vestibular function. Because of ototoxicity, there is vertigo, tinnitus, dizziness, and so we can do the audiogram. And then for nephrotoxicity, we can do the blood urea nitrogen and the creatinine for monitoring of the renal function. And Because of the neuromuscular junction blockade, caution should be there with patients receiving the muscle relaxants, as well as there is also hypersensitivity reaction. With amikacin also, we have to be careful regarding the nephrotoxicity. For capreomycin, ototoxicity, nephrotoxicity, as well as hypersensitivity reaction in rash, fever, eosinophilia, these are reported. And accordingly, we can estimate, do the monitoring and by audiogram, as well as the uh, blood urea nitrogen and creatinine and urine analysis for the nephrotoxicity. And also we have to be cautious in old elderly patient and in presence of the renal insufficiency. Also in with capreomycin hypokalemia, so that is reported. So monitoring of the serum potassium levels is also to be kept in mind. Now coming to the other second line antitubercular drugs like fluoroquinolones. Now fluoroquinolones are oral drugs which are bactericidal for the tuberculosis, and mostly they are well tolerated, but fluoroquinolones are also reported to cause other side effects like the gastrointestinal symptoms, CNS symptoms like dizziness and convulsions, and arthralgia, tendinopathy, and also the QTC prolongation, which are reported with some of the newer fluoroquinolones. So, with moxifloxacin, there is more occurrence of the cutaneous reactions. Then, ethionomide, it causes frequent adverse effects like the gastrointestinal side effects like epigastric discomfort, anorexia, nausea, vomiting. So we can divide the dose, and this can help control the gastrointestinal side effects, or we can give the drug with small meals. So postural hypertension and also behavioral changes like depression, asthenia, drowsiness, skin rashes, and purpura, gynecomastia, impotence, also peripheral neuropathy. So we can treat by giving the pyridoxine supplementation, and also goiter on prolonged use of ethanoamide. So we may have to do the estimation of the TSH levels and treat it accordingly. And hepatotoxicity, as so we can do the estimation of the liver enzymes, so SGOT, SGPT. And if we see prothionamide, this is having similar adverse effects like the ethionamide. Now coming to cycloserine, cycloserine is uh, uh, very much responsible for the CNS side effects like somnolence, there is dizziness, headache, dysarthria, also vertigo, and abnormal behavior, and also psychosis. So much so that cycloserine is sometimes it is nicknamed as psych-serine because it causes psychosis and with suicidal tendency, and also there is the seizures, convulsions take place. And to treat the convulsions occurring because of cycloserine, or for that matter isoniazid, or with fluoroquinolones, we may have to stop the drug, and we may have to treat with giving the phenytoin or valproate till the treatment is completed. And we may also increase the dose of the pyridoxine to 200 milligram per day in because specifically it is seen that peripheral neuropathy can take place when it is combined with the other drugs. So pyridoxine can be given, and as we know, anticonvulsants, they can be used to control the seizures, and most of these adverse effects, side effects, they are more common with the higher dosage. And for psychosis, we can occurring due to the cycloserine or with mental disturbances occurring with isoniazid, we can treat by stopping the drug first and referring to the specialist or the psychiatrist for the counseling. Then terazidone is, however, less neurotoxic and it has low adverse effects. And as far as para-aminosalicylic acid is concerned, it causes gastrointestinal side effects like anorexia, hypersensitivity like skin rashes, and hepatotoxicity, that is SGOT, SGPT estimation has to be done. And for the gastrointestinal intolerance, this is more common in the adults. And in case of hypersensitivity, if it is severe, then we need to discontinue the drug. And sometimes sodium overload is seen with this para-aminosalicylic acid. This is because it is used as a sodium salt. And goiter is also reported. So due to this hypothyroidism, we may have to estimate the TSH levels, and we can treat by giving the levothyroxine if the TSH levels is more than 10 international units per liter. And also hypokalemia has been reported, so we may have to do the serum potassium estimation. So we are discussing all these antitubercular drugs, second line antitubercular drugs. Rifabutin. Now, rifampicin can be replaced with rifabutin if we want a drug to have a less potent and enzyme inducer property. So in that case, rifabutin, it has less potent enzyme inducer property, so it can replace the rifampicin. But rifabutin has side effects like gastrointestinal intolerance, rashes, granulocytopenia, myalgia, and uveitis. So these side effects are there. With rifapentin, rifapentin is having the enzyme inducer potential like rifampicin, and therefore drug interactions are also possible with the rifapentin. So if you want less of the drug interactions and less of the enzyme induction, then rifabutin is a better choice. So now let us come to the newer drugs like bedaquiline, delamanide, and pretomanide. These have been introduced recently for treatment of tuberculosis, and it is also important to know the side effects of these new drugs. Now, bedaquiline is there in the WHO list in 2015, and delamanide in 2017, and pretomanide in 2019. That is recently it is there included in the WHO list. And both bedaquiline and pretomanide, they are approved by the US FDA, and delamanide has been approved in Japan and Europe. So we can see this, all these three drugs have been included in the WHO list, and these are the newer agents. And as per the WHO 2020 guidelines, bedaquiline and pretomanide, they have recently been included in the multi-drug resistant MDR-TB regimens also. So let us see the side effects of bedaquiline. Bedaquiline causes nausea, headache, arthralgia, also QTC prolongation, hepatotoxicity, and also it has the drug interaction potential. So this drug interaction potential is less with delamanide, and delamanide also has better toxicity profile. Delamanide causes nausea, vomiting, headache, insomnia, tinnitus, and also it causes hypokalemia. And we must remember that these newer drugs, they are not to be used in the pregnancy. Pretomanide is causing the nerve damage, acne, vomiting, headache, low blood sugar, diarrhea, and also the liver inflammation. So these few side effects of these new drugs have come up, and we need to also know about these drugs. And pretomanide, it is a drug which is used along with bedaquiline and linezolide for the multi-drug resistant tuberculosis. And it is a reserved drug for multi-drug resistant tuberculosis, which MDR tuberculosis, which is not responsive to the standard treatment. So now coming to the drug-resistant tuberculosis, we know multi-drug resistant tuberculosis, MDR tuberculosis, when there is resistance to isoniazid and rifampicin, and extensive drug-resistant tuberculosis, XDR tuberculosis, when there is a resistance to isoniazid, rifampicin, fluoroquinolone, and one of the injectable aminoglycosides. So we have different regimes given. Here I have discussed the regime in relation to the RNTCP guidelines 2016. So recently we have the NTEP 2019, that is the National Tuberculosis Elimination Program guidelines of 2019, which is based on the drug sensitivity testing. And also recent guidelines in WHO 2020 has given the recent guidelines for the MDR tuberculosis. So I'm not going into the details of the current regimes because here I'm completing my discussion only about the adverse effects which are related to all the different antitubercular drugs. So now, coming to the management of patients with adverse drug reactions to antitubercular drugs, we must see that the dose of the drugs, they should be checked, which should be appropriate to the body weight. Like for example, pyrazinamide 1000 milligram is for body weight less than 50 kg, or 2000 milligram for body weight more than 50 kg. So in this way we can keep in mind the dose of the drugs for the which is appropriate to the body weight. Then fixed dose combination drugs, these are used in tuberculosis treatment. It is justified because treatment for the active tuberculosis requires multiple drug therapy, and this multi drug therapy, it actually prevents the development of resistance to the drug, as well as it also increases the chances of survival and recovery from tuberculosis. All other causes of symptoms should be excluded. Like if there is seizures, we must exclude it, whether it is due to some other CNS infections. If there is hepatitis, it should be excluded, whether it is due to some viral or other causes. Seriousness of the adverse effect should be estimated. If the adverse effects, they should be classified as minor or major. If it is a minor adverse effect like nausea, vomiting, then we can do the reassurance and counseling, or we can give the drug with small meals, or 1 hour, we can give 1 hour after the antiemetic drug. And to maintain the hydration, it is important during the vomiting. And as far as antacids are concerned, this should be avoided because antacids, they will lead to drug interactions. If there is major adverse effects like thrombocytopenia or renal failure, then we may have to change the regimen. So seriousness of the adverse effect should be estimated. Then adverse effect and its outcomes should be documented. The treatment card is there for the patient, and thrombocytopenia or hemolysis, all this should be mentioned, and how it is managed. So it should be properly mentioned. Then the drugs which are needed to be stopped, and drug may have to be reintroduced gradually. So this is very important in relation to hepatotoxicity or in relation to the skin reactions, because what happens in hepatotoxicity, we may have to stop the offending drug, and we may have to reconstitute the regimen. So same is there for skin reactions. So we can do the we can introduce the drug again with small doses, and gradually the regimen it can be reconstituted. Then we must avoid the drug resistance. So this can be avoided. We are using regimens 4 drug 5 drugs therapy, which are very effective. Then symptom based approach is ideal. So if the symptoms are there, we can do the dose adjustment. We can give the symptomatic treatment. For minor reactions, we can reduce the dose, or for major reactions, we can withdraw the drug. So accordingly. Role of corticosteroid, this is there, very useful in treatment of the severe hypersensitivity reactions. Therapy for the multi-drug resistance and the extensive drug-resistant tuberculosis. For these, drug-resistant committees are there in the institution which can monitor, and they can also properly, they can guide in the therapy. Also, pharmacovigilance, recording of the adverse effects of drugs, which should be documented well. And this, we should also evaluate if there is the failure of drug treatment to tuberculosis. So we can check for non-compliance or irregular drug therapy, or incorrect prescribing of the drug, or drug resistance. So the regimens should be based on the drug sensitivity testing. Persisters, like we know, these are the dormant forms and they are not affected by the drugs. Rifampicin has very good action against the persisters. Poor general health, malnutrition, and chronic alcoholism, this can also affect the outcome of the therapy, and associated disease like diabetes mellitus and HIV AIDS. As we know, adverse drug reactions to antitubercular drugs, they are more common in the HIV patients, and considerations must be there for possible drug interaction between the antitubercular drugs and the antiretroviral drugs. As we know, rifampicin is an enzyme inducer drug. It can increase the metabolism of protease inhibitors and non-nucleoside reverse transcriptase inhibitors, making them ineffective. And so sometimes we may have to replace the rifampicin with the rifabutin, which is a less potent inducer. So accordingly, we can do the management of the patients with adverse drug reaction to the antitubercular drugs. So we can see what is pharmacovigilance. It is the science and activities related to the detection, assessment, understanding, and prevention of adverse effects or any other drug-related problems. And it deals with the epidemiological study of the adverse drug effect, which are done during the phase 4, that is during the post-marketing surveillance. And we know there is need for pharmacology vigilance because of the humanitarian concern, that is for betterment for human lives. Pharmacovigilance is needed, and due to the deaths reported due to the adverse drug reaction, cost of treatment, which is increase in the hospital stay and increased burden to the patient. It promotes rational use of medicine, and it is the ethical and moral duty of the health professional to report the adverse drug reaction. And the ultimate aim is the safe use of the medicine. This is the suspected adverse drug reaction reporting form, and we know that the uh, uh, A, B, C, and D, that is patient information, suspected adverse drug reaction, suspected medication, and the reporter uh, details. These are the mandatory fields. And coming to prevention of adverse drug reaction, there are some general guidelines like we should use the drug rationally in the appropriate dose, route, frequency of the drug administration, avoid the abrupt withdrawal of the drug, take the drug history and also history of previous allergic reaction. In this way, we can prevent the recurrence of the adverse drug reaction. Then medication errors or use of OTC drugs, non-prescription drugs, which are available in the market. So these drugs are used for treating allergy, hyperacidity, cold, and in the vomiting. So history of OTC intake should be elicited because these can lead to adverse effects and drug interaction. LASA drugs, like for example, cycloserine and cyclosporine. So same look alike, say sound alike drugs. So this can lead to the dispensing errors. So we should be careful. Check the possibility of the drug interaction. We must rule out the possibility of drug interaction. Check the signs of overdose and toxicity, because if we know the side effects of the drugs, then we can decide whether there is necessary to do the monitoring of the such adverse effects. Then TDM, therapeutic drug monitoring, it is very useful in case of especially when we are using the anticonvulsant drugs like phenytoin and valproate. These are drugs with narrow therapeutic index, so TDM is very beneficial. Assessment of the risk benefit ratio, drug is to be prescribed only when the benefit outweighs the risk. Like in cases of pregnancy, the drug regime which we are using, so many of the newer drugs, they are to be avoided in pregnancy. And patient counseling about the drug, avoiding other medications or drugs from the older prescriptions without the advice. So adequate information should be given to the patient. So pharmacovigilance, we know it is the practice which is aimed to monitor the drug safety in the real life condition and to capture all the adverse drug events during the post-marketing phase of the drug life cycle. And we can improve the reporting of adverse drug reaction by greater involvement of the nurses, pharmacists, and consumers in reporting of these adverse drug reaction, making the process simpler, and introducing educational intervention training program for the healthcare providers, and spreading the awareness about reporting. So at the end, we can see that side effects to antitubercular drugs are common, and it includes hepatitis, cutaneous reactions, gastrointestinal disturbances, hematological reactions, and renal failure. These adverse effects must be recognized early so that we can reduce the associated morbidity and mortality associated with the tuberculosis.